Always a challenge. Let's sign in, share. Here we go. Let's see what happens. All right. Well, two columns or three columns. Maybe we ought to have four. Well, it's a great honor to come back and speak. I've done trauma for 35 years, and actually I did a course with David and Ashif a couple years ago at NAS, and they certainly are going to be the next generation, thank God, because trauma is not often spoken about at any meeting, NAS included, because it's just not done by a lot of people, and it is different than deformity, which really commands the stage now and everything. So, um, this is what I'm faced with
Oh no.
because people do crazy things all the time. Although I must admit, I might like to try this if I was younger. But we get a lot of really crazy injuries and everything, and people because people do crazy things, and things. But when you talk about classification, this is the timeline of classification. Every 10 years, another group of budding spine surgeons come along and basically create another fracture classification, as you can see here. We're starting with Bowler and Chance, Nicole, Holdsworth, and then on to Francis Denis, McAfee, who's present, and then on to Magarall, and of course then on to the most recent classifications by Vaccaro. And so we really haven't done a lot as far as new concepts. Henry, when you look at Boulder's contribution, he was an Austrian surgeon. Got a little trouble because he supported the Nazi Party, but he did run some people think that anyway. He ran the Vienna Trauma Hospital, and he was very meticulous. Anybody know what the Boulder clamp for calcaneal fractures is? But you can see at the bottom there, he described all the things we described to this day, way back in the 20s and 30s. And if you don't believe that, here's his pictures of basically the different kind of fractures: burst fractures, compression fractures, fracture dislocations, jump facets. All of those things he described 75 years ago are incorporated into the current modern concept. So nothing really changes. We just kind of reshuffle the columns, I think is the best way to think about it. He would actually inject these to try to give patients relief. And here you can clearly see a classic GQ chance fracture. And then he had a nice classification of sagittal balance that came long before the French classifications and the ones we have now. And so the great surgeons will all think the same, maybe in a different time frame. And after Bowler came along, there's a famous Watson Jones who described wedge fractures, seven different kinds, as a matter of fact, comminutive fractures, fracture dislocations, way back in the 30s. And here's a video I dug out of his university archives that shows him basically doing a cast for a burst fracture, a hyperextension cast to raise the anterior column and perhaps the middle column, if you believe in that. And here he is. He's going to just hyperextend this guy and mold a cast around him and successfully reduce this fracture. And here, I'll show you a quick picture. This is just historically so interesting. Yeah, I'm sure we could do this to a patient nowadays. Look at that. They'd be very cooperative on the table. But I'm supposed to kind of go over a little bit of history. And this is the way they used to do these fractures. Quite honestly, all the way up into the early 70s, you would put hyperextension casts on these guys, and you would get remarkable reductions. And I won't play the whole video. You can do that on your own. But the bottom line is he got a great reduction with this, and it shows him walking around. And here he is extending his back, as you see here, doing extension exercises. They made him do that in bed. And these things actually would heal up pretty reasonably well, which a lot of people went to anterior resections all the time with Francis Denis, and basically, but we now kind of are in the middle with particularly some of the Canadian literature where the burst fractures heal pretty well as long as they don't have neurological problems. And Nicole came along and made another classification, basically in 1949. Here we go, every decade: anterior wedge fractures, lateral wedge fractures, fracture dislocations. And he noted that most of the fractures occur at the thoracolumbar junction from L1 to L3, which is true to this day. And it was kind of one of the first guys to point that out. And a perfect recovery is possible if you get a perfect reduction. It was Watson Jones, what he was pretty much advocating. And of course, Nicole said all fractures should be reduced and casted and with prolonged bed rest, and that's where that came from. And his conclusion were that if you do not basically get a good reduction, then you need rigid anterior fusion, okay, versus spontaneous when you have to operate, in other words. This is way back in the late 40s. And a posterior fusion was necessary to reinforce the anterior fusion. We do this to this day in one form or another. Now, Sir Frank Holdsworth came along and he established the two-column model, just a better way of perhaps thinking about it front and back, which part of the spine gets destroyed. And now we now know that the posterior column is critically important in the PLC, but he described this way back in 1970. It is not a new concept. And he reviewed over 1,000 patients and came up with the classic flexion rotation, shear, pure flexion, vertical compression, or burst fractures, and of course extension injuries, which was a little bit of a new addition through an ankylosed spine, because that really wasn't thought about with ankylosing spondylitis or with DISH that we see with an aging population. A lot of these extension injuries that can be quite devastating. And he actually would plate these with plates way back in the 60s and 70s. And he came up with the classic two-column injury, as you see here, with damage to the PLC, and started everything as far as publication and getting these things out to where there would be some sort of codification of how to treat these fractures and everything. So he actually got knighted for that. So that's a pretty good result of that. And then when I started in medical school, um, back in the 80s, of course, Francis Denis looked at the fractures in Minneapolis, and he came up with the three-column model, which some people debate, some people don't debate, along with the McAfee model. But the bottom line was that when you looked at what he was operating on, it was a very small portion of the 412 patients that he made the recommendation that all these anterior burst fractures virtually there was a huge upspike, just like with posterior column osteotomies when they were popularized, in the number of people that were getting anterior surgery. And so he divided it into three columns: the posterior PLC column with the facets and everything, and then the PLL and the posterior part of the vertebrae, and then, of course, the anterior column consisting of the anterior third of the disc and the ALL. So pretty simple. I mean, you can divide the spine up into three columns, four columns, whatever you want to do. But the bottom line is, it was just another way to look at the same things that Bowler started looking at almost a half a century before. And he came up with various different problems. But what he said was that fracture dislocations are bad actors and involve all three columns. And when all three columns are involved, you better stabilize these patients, which is what everybody started to do. And unfortunately, sometimes when they did it, he also recommended that an anterior burst fracture with debris in the canal and involving that middle column probably warrants a anterior vertebrectomy, which is not always the case, quite honestly. And I actually did many of these, and with an anterior approach, which is relatively simple. And but I probably don't do nearly as many as I do now, particularly in younger people because they heal. So then Magaro came along and basically created the type A, B, and C classification, which are just a reshuffling of a vertebral compression fracture, minor fracture, type B, which is an anterior posterior with distraction of mild fracture dislocation, of course, type C, which are the really unstable ones where you have any sort of lateral translation or rotation is a very profoundly unstable fracture. And he pretty much said they all should be operated on when they're that classification. The trouble with this, as you can see, it's a very, very complicated system. And I suppose if you're trained on it, you should be able to look at these quite honestly and apply one of these more simple classifications and know whether or not they're going to be stable. And the key that we're going to get to is the posterior column, quite honestly, particularly in patients that have good bone quality. Now, keep in mind that all of these classifications are in a vacuum. They do not take advantage or really appreciate the problem of having osteoporosis, which is what we face now in older patients, because they can dramatically change how you apply these classifications because the bone substance does not behave like these classifications address. And these are the three kind of injuries that you have. And generally, the B's and C's usually will require some sort of stabilization. And occasionally the A's if there's significant canal compromise with a burst fracture or some sort of neurological injury. Now, the important thing to point out with Magarel's was he didn't include neurological injury. So enter Alex Vaquero, and I was part of the spinal deformity trauma group that really validated the TLIX classification. And what he really looked at is he added neurological injury for the first time to the classification, which I thought was very critically important because that really drives most of the time. If you've got neurological injury or progressive neurological injury or an incomplete lesion, I think it's fairly well accepted now that you ought to get the pressure off the spinal canal. And we did rat studies years ago where if the longer we left debris and the canal compromised, the worse the neurological injury and the less likely that the test animals will ever be able to ambulate again. And that was very clear cut when we did it. We could see that if we got them decompressed in 6 to 8 hours, they actually would walk. And if we waited 24, they would never walk again. But remember the black stripe sign. and the ligamentous injury, because that's responsible for 30% of the lumbar stability, which is where a lot of these fractures tend to occur at the junction. And he really said that if that was disrupted with the scaling system, which you're probably all familiar with, less than 3 points, no surgery. 4 points, equivocal. 5 points, most likely you're going to need to have some sort of surgical intervention. But it was not specified as to what type. Okay, and it's a relatively simple system to apply, and it divides it into those three different things you want to look at. And so you go down the algorithm and you look for axial compression, you look for translation, you look for suspected injuries, and you add them all up. And basically, when you get 5 points or more, which gives you a little bit of wiggle room, then you would stabilize them. So real quickly, like look at this. Okay, what's the TLIF score going to be? Well, it's going to be like astronomical. It's going to be at least 10. So this is a patient that's neurologically compromised and will never probably walk again, but it's going to need to be stabilized long term so they don't develop a Charcot joint. So the problem with that was it was validated. There were a couple of people that went over it and it had pretty good reliability. It was also done in children that we'll show you later on today, and it seems to have good reliability. It's quick and simple, and it's the system that we tend to use. Well, that wasn't good enough. Alex went and basically with owner and applied and combined the neurological problem with which Magarol said he originally was going to include in his classification, the Swiss classification, and he added it to it and came up with this new system here that's more complicated and moves more toward what the Magarol classification is, adding the neurological status. So any neurological problem, you probably are going to require some sort of surgery unless it's a low lumbar fracture. So they came up and added the N0 through 4 and some other modifiers. And again, it makes it pretty complex to use, and I'm not sure how widely it's accepted and everything. Now, we also have to look at complications and everything, and the bottom line is steroids or no steroids with these people. It's still equivocal to this day, but there's probably some of the people are saying give some steroids because what do you have to lose? Well, what do you have to lose is it really dramatically raises your complication rate, as this study clearly shows. So you have to keep that in mind. You can see the odds ratio of having problems. And the real bottom line is the Asia A's, need to stabilize them for long-term effect, but it's the Asia B through D's are the ones that you really want to stabilize, decompress the canal either anterior or postally on these thoracolumbar fractures. So there's some other kind of classifications that come up. Here's a thoracic classification without spinal cord injury, principles of management. These tended to be lower grade by CANA that you just stabilize in some fashion or another. It doesn't really matter what. Here's another one by Ginatabai, who basically said you could fuse a level above and below. I would not recommend that because that was done by another classification system, and they did above and below. And if they didn't have anterior column support, they would fail. So you got to be really careful if you have a lot of comminution, the McCormick classification. In other words, you might not want to do that. So when we look at people, we'll look at some cases and some examples. Young people get seatbelt injuries and chance fractures more commonly, and then you start to get a lot of burst injuries because young people spread the force over many levels, while older people really tend to just concentrate it in one level. So as you get older, you start to get more of these hyperextension fractures and Cummel's disease and osteoporotic fractures, while the younger people really get the fracture dislocations, the seatbelts in particular, and the bony chance fractures. So they are a little bit age stratified. They're generally high energy injuries. This is an accident that we had a couple of years ago in Louisville. There's the light pole, and then of course you'll see the light pole inside the car. Needless to say, we didn't have to operate on that patient. So there's kind of 6 vectors of rotation, right? There's rotation, flexion, extension, and translation, plus compression. And you have to factor those in to when you're thinking about doing some sort of correction. And you can see here all these different fractures you can get. And fractures are not often clean. They're not just pure seatbelt injuries where you tear the ligaments that you see in children. In adults and a lot of the people we see, I mean, they're combination injuries. They may have some translation, they may have some rotation, they may have a bursting component and also a flexion or distraction type injury. And so you have to really look at all the studies. And of course, you can even have lateral shear injuries that we'll show you a couple of cases of. So when you're doing these patients, the first thing you're going to want to do is posture reduction. Whether if they're open in the front, you put them on a Wilson table, put the gears at the top. If they're the other way around, you put them on a four poster, and so you can do a great deal of posture reduction. I always recommend that you do MEPs before and after you flip, just to document it. And then you can also do iliac crest bolsters and actually reduce the opening hyperextension injuries. And if you want a compilation, Kumar wrote an article where he talked about all the different ways to reduce these fracture dislocations. Unlock, Distract, Manual Reduction, and we'll show you some of these as we go through some of the cases. It's a good article to review because it just has nice pictures to show you all the different constructs you can do, regardless of the classification. These are all fracture dislocations that demand stabilization either for neurological compromise or to preserve neurological function. And it's a really nice paper that you can go through. You almost always will need some sort of guidance, either fluoroscopy for these, remember to wear your lead, or I generally tend to use the O-arm to guide. I just think it's more precise on these patients. So you need good radiological viewing of the reduction that you can get on these patients. So here's a lady that fell. She basically had a lot of back pain and leg pain, and she was seen by probably 6 different surgeons. And this were her original x-rays. You notice that they kind of didn't notice that she had a pelvic a rami fracture bilaterally, and she also had a sacral fracture that they kind of missed. So nothing was done for this. And as time goes along, she eventually had an x-ray in the ER that noted that she had a fracture. And now you can see she's starting to slip and displace. Okay, you can see she's got a transverse process fracture of L5 that is often associated with this. She's now got a fracture on the opposite side also. And then she comes in paralyzed. Can't move her. It really has a cauda equina, acute cauda equina. Can't urinate. Can't move her feet. And so she comes in and she was diagnosed and referred to us for a tumor now. Well, this isn't a tumor. This really is a hematoma coming out of that sacral fracture that's causing cord compromise because it's moving and grinding bone, and she's osteoporotic, which they didn't factor in. And so we basically had to go in, and you can see how it's eating away the bone away with the hematoma. It does kind of look like a tumor, but look at her bone density. It's terrible. And those are things you have to consider when you're treating trauma, is their bone density and get them started on some. So we did this, and you can see that she goes ahead and actually heals, and her cauda equina recovers because we decompressed her, and she does well long term, as you can see here, and heals this thing. So we're kind of going to go through some of the basic directions, whichever one of the classifications you'd like to use, and I highly recommend that since Paul McAfee is one of the faculty here, that you use his classification on every one of these. But but you can use any of these, I think, and get good results. So a flexion dissociation injury, basically there's a pivot point in the front. It'll widely distract all the way to the ALL and sometimes even tear it. And most of the time they'll get a recoil reduction. But all of the posterior ligamentous column is destroyed. The third column, most likely the middle column is destroyed. And also there's maybe even damage to the anterior column, the anterior third of the vertebrae. So these are patients that come in with pictures like this in the ED, and then you get your CAT scan, and basically you're going to see that that things are widely displaced, the facets are jumped here, and the cord is compromised, and these demand emergency surgery. And you're going to take the patient basically to surgery and reduce this, and it will show you a quick picture of how to do this, and you can see this is post-reduction. And the best way to do it, in my opinion, is one of the things that was in the article by Cantor, was basically put in 2 rods and just physically reduce these facets and get them reduced back into position. Now, here's another 32-year-old female that came in, and I just happened to be on call for this. And basically, again, we placed it screws above and below. In this case, we went 3 above, 3 below because she's so grossly unstable. And we're going to go in and get rods above and below. And we're going to just simply reduce this. Jump the facets over and push it down, as you can see here. It's hard to get a picture. There you go. Did you see it just pop down? So you can see we get it nicely reduced, and it gets into position. And that person was partial and actually recovered. Now here's a lady that was ejected going 80 miles an hour. And this is the famous bayonet fracture, okay? And this patient's complete. She's torn her cord, as you can see, in 2. She's grossly unstable. These can have a significant aortic event when you reduce them. And you can see all the blood in the, look at the soft tissues, always do that, and look at all the blood in the retroperitoneum, as you can see here. And this is really a challenge. So you're going to have to get control, just like with any fracture, of the proximal and distal fragments. You can see everything's ripped in 2 here, and she's just amazingly destroyed. You can see the step off there. And we could not get screws in the top because she was bleeding so profusely that we went ahead and just threw in a quick hook construct and just popped her back into position. As you see here, she's reduced now, and grafted her, and she actually was complete, but she did relatively well once we got her out of bayonet apposition. So these are the kind of things. This is obviously an all-column injury that really requires significant surgical intervention. Now here's another patient comes in, has clearly had a three-column disruption or a two-column disruption. It doesn't matter. Either one of those is going to be a flexion distraction injury with sometimes a burst component. You can see the fluid through the disc there and the posterior elements are involved. You see all the retropleural fluid from the bleeding. So look for all that. And plus in the back, when you see that, you know it's multi-column. And you can see here, it's all busted up in the back. The facets are broken. And we're going to have to basically reduce that, and you can see do a decompression here because there were some fragments in it. To see the bilateral jump facets, that's actually the inferior facet. The superior facet's in front of it, and we're going to bring that back and reduce it. And like you see here, we've got it reduced down. We're gonna pin on our other rod. We have control of the fragments above and below. Again, using the classification system, two column or three column, doesn't matter. This is a 360 degree, and this person was a big, strong male, so we did a four rod construct and multiple screws to stabilize him, and he did great. Now, these injuries can occur in skeletal mature adolescents, and here's a girl that comes in, and my partner did this, Dr. Glassman, and fortunately I traded call with him, so he got stuck with it. But this girl comes in after a car wreck. So you can see this involves the posterior elements, the anterior elements. It's a two-column injury, Holdsworth, three-column injury, everybody else. And you can see the facets are jumped, and she's neurologically 100% intact. Very high-risk case. Our AMPs were normal before, and you can see how everything's ripped in two in the back also. And there's got a little bit of epidural hematoma and the paraspinal bleeding that they get. And we just gently reduced her and got her back to position. She came back very nicely, and she had a very harmonious result of that and did well and was Asia E. Now, chance fractures are bony injuries just through the bone. There are four different kinds, and some of the injury pattern can actually exit through the disc or in other areas in the spine, and it's not always just pure bony. And so they're kind of lumped together, but they really occur it's a flexion distraction kind of injury where you slide forward and the crack just occurs right through the bone. Usually you'll see a split pedicle on the AP coronal view. And these usually occur in younger patients less than 30. It's rare to see these in older patients. And it's a three-column injury, period. It should be fixed. Okay. And you can fix it just posteriorly because your anterior column a lot of times will be intact. Now, Jiju Kantz he was not British. He actually was an Irish radiologist that gave a report of three cases of this and was the first to notice the pattern, as you can see on the right, just like we see today of the split pedicle. And he recommended that they be stabilized in some fashion. And he died interestingly in Tangier, Morocco. So here's a 30-year-old female involved in a rollover, and we'll take a look at her and you can see how she split on the MRI right through the vertebral body. And we'll go back to sorry. We'll go back to geez. Sorry. Here we go. I just wanted to show you the CT. Here we go. There we go. See how it split right through the body? Classic injury. Easy to do, even though it's really a two and three column injury involving all three columns or two columns, if you believe in Holdsworth. We went through this. You're going to have to get it back reduced, and a lot of times you can just reduce it on the table and stabilize it. Okay, the canal will usually be okay, and there's not a lot of fragments unless there's a bursting component to it. Okay, here's our team, and you can see how it's all torn right in two here. Okay, and we're going to reduce that with a wire to get in a position to hold it. We then put in our screws and rods. It doesn't really matter what you use because these are broad bony surfaces and they heal up really quite nicely, as you can see here. And so as you look here, you can see we've got it nicely reduced. We've got a 0 degrees of kyphosis or lordosis across the thoracolumbar junction. Remember to try to restore, you don't leave them kyphotic, you don't make them lordotic, you make them neutral because that's what it is over those segments and everything. And we've got it nicely reduced. Now, a seatbelt fracture is differently, and I included this here, not in the pediatric, just to show you. It's mainly a soft tissue injury. So here's an 11-year-old that I saw, high-speed collision head-on what we call Dixie Highway south of town. Somebody was passing somebody. Major injuries, laceration requiring a ostomy. She's Asia D, has a lot of lower extremity burning dysesthetic pain, and we're going to do her. And the basic mechanism of these is this, is these children, even though we have lap belts, they put the lap belt behind their back and they just wear the seat belt. And we know that from historically, that's going to likely result in a distraction kind of injury where you actually tear the ligaments, and particularly those would be children that are less than 10 or 11, and they'll just tear the ligaments all the way through the posterior spinal ligaments, through the capsules, through the PLL, through the disc, and even up to the anterior ALL. And they'll continue by damaging the spleen and even tearing the aorta and getting a aortic laceration, which we've seen. Sometimes they'll even between it, it can be so distracted between the things. We wrote a paper on that years ago. So this is what it looks like. You can see it's mainly a soft tissue injury when you get a seatbelt injury. I do think they're distinctly different than chance injuries because of the age they occur in. You never see these in adults. Uh, I haven't anyway. And they basically work like this. So around the pivot point anteriorly at L3, which is where the seatbelt's sitting. Now remember, between that and the abdominal wall is the spleen and all the other soft tissue contents. And so this is what it looked like. This is a pretty bad accident. They showed it on TV, and unfortunately my a patient was in that upside down car right there. Her sister, who we also treated, who had scoliosis, she died in that. And this guy on the right is the guy that caused it, who walked away from it by illegally passing. And so this is what we saw. It's completely torn into all the way through the ALL at the L4-5 disc space. And so she's got a little fracturing of the bone. It's probably the PLL that's pulled off there. Her facets are laterally displaced. When you see spread facets like that, or sprung facets, we call them, it's unstable, okay, or they wouldn't be sprung. And a lot of times they'll be just frankly jumped. They probably were. And you can see that this still looks kind of normal, but the ALL is torn. And you can tell that because look at all the psoas blood there. So this is a very unstable injury. So we went in and repaired it. You can see that everything is torn, including the fascia, which you'll see with these. It'll actually tear out laterally, and we'll always kind of repair that so it heals in position. And we'll need to reduce this, which we did. And because these are terribly rotatory unstable, you should always add a crosslink if you want to do a four screw construct. You can get away in doing this in children because they heal in 4 to 6 weeks with callus, while an adult, particularly if they're osteoporotic, may take 6 months. So if it were an adult, I probably would fuse longer. But this is a little bit of a special circumstance with these kind of injuries. And you can see she does well. And this girl is now 8 years after this, and she's one of our research associates. So we'll talk briefly about fracture, dislocation, and rotation injuries. These are the worst. They involve all three columns, 2 columns, 2 to 3 columns. They involve the anterior disc is torn, all the posterior links are torn. The supraspinous ligament is will be disrupted. You'll see a black stripe sign. And this patient came in Asia A because it's such a displacement injury, either from getting entrapped in like an industrial accident, but they're usually high-speed auto accidents with ejections. And they really work like this. And in addition to flexion and rotation, flexion, you get a rotatory pattern where you get a lateral side bending pattern. And basically, this is what they look like. They're almost always complete injuries, but they still need to be stabilized to prevent the development of Charcot joints and things like that down the line on these patients. And you can see on the X-ray, you can see how they're rotated on the 3D reconstruction. And this one's so torn apart, we actually were looking at the pleura. So it can tear all the way through the interspinous membranes, either in the lumbar or between the ribs, and you'll actually be seeing pleura there. You just lay a sheet of muscle over it or just repair it if you can. You do a preliminary reduction in this case where we got in our screws and got a reduction rod in there. And then we did a long fusion on this patient because this was so grossly unstable. They did not recover. The other one is a dislocation burst injury where not only do you get an extreme flexion moment and tear all the posterior ligaments, but you also get a lot of compression. And you'll see these with rollover injuries. And well, I'll show you some other ways you can get it. And there's always a palpable gap. And this boy, it looks like this as far as just kind of sometimes they'll jump their facets. You can see how the vertebrae collapse down. And instead of just adding flexion, you add a significant axial load. And you may have to address that depending on how bad the bone's destroyed. You may need to do an anterior and posterior. If they're really bad and they don't have a lot of concrete operators, I'll reduce them posteriorly and then put something anteriorly as an option. Or you can go anteriorly if they have a lot of debris in the canal anteriorly. Either way, you need those kind of skills to do these. So here's a good example of one. You can see how it's broken, a 3-column injury all the way through, and the interspinous ligament is torn. So we're going to do a long stabilization on this because he's so stable. And again, this patient we did a decompression on and he recovered. And here's another one that comes in, polytrauma. He's Asia E, and he has this kind of what we call a lateral shear injury, which is really rare. And this is where he got bent sideways and then compressed, and it just cut right through. It'll involve 3 vertebrae almost always. And you put an axial load on with a lateral shear, and the spine will actually go to the side. It's not often described, and I'm not sure. It certainly involves all 3 columns to some degree. but it's unstable. I want people to think of more instability patterns than just automatically classifying them, because you can see that's been done for 75 years. So you can see this fracture propagating through three vertebrae. You can see it on the CT scan here where it's pushed to the side, and you can also see it on the MRI. And this is one that we went in and stabilized. They're very rare. I've only seen like three or four of these kind of injuries, but it is a definite pattern to be aware of. And another pattern in the older patients, remember how I show you how they're stratified over ages and everything? Here's a patient. This guy got involved in an industrial accident. And so basically he got rotated and laterally displaced. So it's a combination of lateral shear, rotation, and flexion. And so he's got this terrible injury that you actually see a double vertebrae sign, like you see with a spondylolisthesis, only it's lateral. And it's one of the few times I've seen this, but you can get these tremendous injuries. And remarkably, the only thing that he seemed to lack when we took him to surgery emergently was he couldn't dorsiflex his foot, so the nerve was torn. So we're going to have to reduce this multiplanar. So it's important not to think just in columns, but also three-dimensional anatomy of where you have to put the spine back into position and what's going to be bothering you. So we go in and try to dissect from outside into the fracture site. You want to do that to get normal anatomy to abnormal anatomy, so you can get your screws in and to show you how unstable this is. See if this will play. Media not found. Okay, it's gone. Anyway, so we basically got screws above and below and reduced this. We decompressed it and unlocked the facet right here. It was entrapped and the nerve root was underneath it. And that's why he had a nerve root palsy there. And he was stabilized and he completely recovered, amazingly. The hyperextension injuries are what you see in the older population. They're with ankylosing spondylitis in particular. They're all kyphotic. They fall on their face and they hyperextend, or you see it commonly with dish. And it just simply looks like this and really behaves in this fashion here, where you extend the spine, you crack the osteophytes. In these cases, some of the posterior column may actually be intact, and when they reduce, they may be stable. So sometimes we'll treat these in a brace if they're not displaced in any fashion. So here's an example. You can see how it's broken through the end plate. It's now reduced back when you take a picture. But when you lay them on the table, if they're kyphotic, it'll open back up, and that's how you tell they're there. So these should be also stabilized. A lot of times, if they're osteoporotic, I may use some carbon fiber instrumentation on them to match the modulus a little bit better, and they'll do good. Now, these are the worst things, is a lot of these people, like when they fall from beer stands, deer stands, we call them beer stands in Kentucky, they'll break multiple vertebrae, and they may have a combination injury, as you'll see here. So this gentleman fell out of a tree and basically had a chance type injury through the vertebrae, all three columns, and also had a compression fracture burst injury below it. And he was, of course, I believe he was complete. He was Asia D. So we basically took him back to surgery, and you can see it's easy to miss these. We could have missed that chance type injury above and compression injury. So we treated both injuries, decompressed him at both levels, and did a long fusion just to protect his neurological elements to make sure that he would be able to walk after surgery. So to leave time for questions, I've kind of gone through the treatment of the history of these thoracolumbar fractures. Keep in mind that the concepts of these have been around for 75 years, and we just kind of change them with every new generation of surgeons. So we're due for one of maybe David and Asher can make a new classification system and rearrange things so we can get a new thing. But it's important to think about concepts and stability and what's happened to the spine. And when things are out of position, you have to think about how you're going to get them back in a normal position and preserve the neurological elements. And this is frequently in a patient that's got polytrauma that are very, very sick. Every study we have done shows that the faster you get these people stabilized, the better they're going to do. The less likelihood of a secondary neurological injury, the less likelihood of a damage to the core from the penumbra of swelling when you decompress it, the less chance that they're going to get pulmonary problems, particularly thoracolumbar fractures and thoracic fractures have clearly been shown if they're stabilized, they leave the hospital much sooner, they have less ICU time, they have a much lower incidence of pneumonia because you can sit them up and mobilize them, even if they're paralyzed. So these patients demand very special thinking, okay? The different patterns require different strategies. Most of the time, you need some sort of open reduction. Now, you can do these minimally invasive if they're neurologically intact, but if they're not neurologically intact, you better think about, opening them up at least at the fracture site and clearing the canal of any bones. And keep in mind, you're very likely going to be doing a dural repair. So sometimes it may not be a good idea. Generally, I can do one of these cases in a couple of hours, skin to skin. In a patient that's got polytrauma, that you better get done as fast as you can. So you don't want to be messing around and taking a lot of time. Any incomplete neurological injury, if it's compressed, it requires immediate open reduction and decompression. And by far, pedicle screw fixation provides the most stability, particularly when you grab the fragments above and below. Finally, anterior column support. If the anterior column is broken, it needs to be repaired and reconstructed. Now, it's very difficult to do that, and I do a lot of costotransversectomies and things along that line, and you're almost always going to have a dural tear, which will be impossible to fix because the dura is torn circumferentially. So, you might want to consider a front and back on those if they have significant injury. So, anterior column support is still a mantra when you lack it and everything. And so that pretty much concludes that. So we can have some questions now for 5, 10 minutes.
First of all, thank you, John. This is Jens, very comprehensive. Can we go on large screen? So thank you for joining us. By the way, this is the man who's taught me the concept of encephalization, which if you ever wondered about how we to be in our evolutionary pyramid, where we are in the pecking order, if so will, of life, our spine had an integral part in this to allow our brain to grow. So, and in Dr. Dimar's case, that spinal column has to be very profound because he's an amazingly wise and smart person. So much to learn, so much to unpack. I have one simple question. Bracing. You showed those cast pictures with Dr. Bowler, and I'm old enough at Harborview in my 25 years that we actually treated a fair number of neuro-intact patients with these extension casts, and they were very effective. Braces were viewed with skepticism, and Canadian studies have shown that they don't really work very well. Do braces actually work? Do they have a role, or should we go back to maybe for patients we don't want to operate on, learning how to cast patients?
Well, it's as usual, it's a loaded question.
Course.
But I mean, it depends on the patient. I mean, every patient needs to be treated individually, and all those fractures are different, and you have to think a lot about them. There's probably pretty good evidence that a burst fracture in a patient that does not have osteoporosis and will develop Cummel's disease or collapse or kyphosis probably does okay with just a simple TLSO brace. And even further so, the Canadian study showed that the TLSO braces aren't even necessary. Although that's kind of hard to get away with, period. The problem with a lot of these patients is you very rarely see a burst fracture isolated. It's not very common, and they always are polytrauma patients that you've got to get them fixed because they got to get them out of bed or they're going to die of PEs or other problems. And so, there's absolutely no question in a time when we had hyperextensive casts, they clearly work. You should watch that video because you guys have a copy of it and watch that guy gets up and walks around. It's amazing. And it's completely reduced from a pretty compressed injury. But he's a young guy and he's got good bone and healing capacity. And you have to take that because I'm a bone kind of specialist too. I take that always into account and have for 30 years. And so yes, braces do work. They're treating the patient and they're also treating you. But in a lot of these polytrauma patients, which is most of what I showed you, I have to get them up and get pulmonary toilet and get them out of bed and be able to safely rod their femur and fix their forearm without paralyzing them. So we're the first guy on the hit. Once they're stabilized, trauma sends them to us and we get them fixed. And then they can do the rest of the stuff that day or next day without fear of damaging their spinal cord. So that's the main impetus to why we probably treat more of these open now. Does that answer your question?
Yes.
Dr. Dimar, thank you so much. This is Ashraf. It's a very comprehensive talk. And as always, the block diagrams, I'm so appreciative of the block diagrams and the animations that you have in your talk. They're quite helpful in, depicting what's going on, and I imagine time consuming to generate. My takeaway from your point is I still need to think about the injury. I can't just put it into a bucket and treat it. And you gave a really good sort of a discussion on the evolution of all these classification systems. Are we done classifying and reshuffling all these injury patterns, or are there still like some gaps in terms of like how we identify patients? You mentioned like the patients with osteoporosis, we might need to think about differently.
Yes. That's why, well, you and David need to do that. Okay. I mean, that's your job because it's interesting when I told you that generational thing is we listen to our own generation a lot of times and the friends and people that and you ask their opinions at meetings. And so it's important that like your generation of new spine surgeons probably should create their own new classification system, and you incorporate the best of the old and add the new. And what you need to add is the age of the patient. Okay, because absolutely a compression fracture in a 65-year-old osteoporotic woman is catastrophic if it develops AVN and Cummel's disease, correct? And those people end up getting operated on. Okay, well, there's a chance that if you treated their osteoporosis, they might heal and you won't need to do anything. Then that's dramatically different than a fracture dislocation in a car rollover that's 35 years old that you may get away with a short construct and a little bit of biologic in there and get them stabilized enough that they can rod their femur. And so I do think that there is need for an additional, just like Alex added the neurological thing that had not been placed in the Magara classification, you guys should add, well, maybe you need to also take a look at those Hounslow units and decide if you're going to fuse longer or you're going to immediately start a teriparatide or some other thing like that to treat these patients. Because a lot of patients we see are over 60 and we go in there and put in the screws and their bones like butter. So yes, I do think there's a reason for classification, but the concepts are the same. But we know a little bit more about other things now that you can add into a classification, and you should put in there check the Hounslow units.
Thank you.
Okay, be a great paper for you.
Yeah, Dr. Dimar, I think that was a fabulous talk and kind of echoing what everyone has said and kind of looking at the talk. It seems you talk about the classification systems being reshuffled every 10 years or so, but one of the things that I noticed, it's every time it got reshuffled, it was with the advent of some new technology or some new technique.
Exactly.
In the 20s, you had the X-rays. Then a bit later, you had the advent of CT, and then you had a new classification, then the advent of MRI. And then it's not just when it was invented, you had to have enough imaging
Sure.
of those patients, or the advent of the pedicle screw, which gave us more capabilities. And so taking all that into account, now that we're in the generation of navigation and robotics, how do you think that will change how we classify and design our new classification systems?
Well, I think you're correct. I think that the best example of technology changing the classification system was the MRI and looking at the posterior ligamentous complex in detail and seeing the black stripe sign, which led to Alex Ficcaro's classification. In addition to adding neurologic, that's one of the kind of the alternate benefit of that system and everything. I think that I think that the advent of pedicle screw instrumentation was a somewhat of a transformational change for trauma because I think it's just immensely more secure and you can reduce the spine much better because of the ability to hold the segments using pedicle screws and rods and everything. And I'm not sure robotics is just another way to put in a screw. And I've used we have a robot and I actually sat down and did quite a few cases with it. And it in a trauma patient, it will add significant time to the case. And compared to just classic image guidance, which is also a transformational change, I think that's probably the last great transformational change was imaging, guidance and everything, because it's made us all better surgeons and able to do things we couldn't do before. So I think those have already been incorporated into our treatment algorithms now, those two technologies, quite honestly. And if you're good with a robot, you might use it so you can publish. And if you're good with image guidance, you're almost always going to use it because it with a good team, you can do it just almost as fast as you can by just manually putting in the screws. But these patients are very sick. You don't have a lot of time to, even with minimally invasive, if you're slow at that, you probably ought to open them up and do them quickly with guidance or something because they can go south really quickly on the table and can be very traumatized, but you got to get them stabilized because neurological function is of great importance. So, yeah, you're right that the things have changed with technology advancements, but they're. I'm not sure if those two things you mentioned haven't already been incorporated. At least we've used them for that. Does that answer your question? Sort of.
Yeah, hey, John, Paul McAfee. I'm going to help answer the question a little bit based on what we covered yesterday. But I really enjoyed your talk. Very, very comprehensive, and there's so much information there. In terms of my classification, I don't really care for people trying to pigeonhole, individual fractures into a scheme, particularly the one that I came up with Francois Denis. I enjoyed very much your idea of the pivot point And just so you know, the reason we came up with a concept of the middle column is the natural IAR, instantaneous axis of rotation.
Right.
It's at the junction of the anterior 2/3 and the posterior 1/3 of the vertebral body in the disc. So the normal biomechanics, see, Fritz Magerl's an anatomist, so he's looking at anatomy, and he didn't, we worked together on this, but I could never, he's an anatomist, so he wouldn't buy the concept of the middle column because it's not a separate and distinct anatomic structure. But I tried to argue that I didn't really care. It's a concept, just like the posterior malleolus or the femoral calcar. The junction of the anterior 2/3 versus the posterior 1/3 of the vertebral body, it shows that the two columns are kinematically different. Now, once you get into something like a seatbelt injury, then the pivot point changes, and that's why you have distraction across all the columns. But in terms of robotics, the key thing is a lot of your cases were unstable, and it's really two spine segments. And if you're going to approach that with navigation, the whole key is you have to have the DRB, that's the dynamic reference base, on the same segment that you're working on.
Right.
So in other words, you treat it like two different operations. There's a segment at the top and the segment at the bottom, and you do not put the DRB on the top while you're putting pedicle screws in the bottom and vice versa. Or if you had some of your complex injuries with three segments, then you got to do three spins and three different.
Yeah, we do. We'd use two frames.
Yeah, that's right. That's what you got to do. Now, in terms of the middle column, I'm just about concepts. And the reason it made sense to me is it's like the posterior cruciate ligament being the central stabilizing structure of the knee. It's very, very rare to see an isolated PCL injury. And I was going to challenge all the residents and fellows here and Jens to try to come up with a fracture where, I believe the middle column is the central stabilizing influence of the spine. And I haven't seen it where you wreck the middle column, but the anterior and posterior columns are preserved. So, and remember when this is in the 70s, there was really only three treatments: Harrington distraction rods, Harrington compression rods, and then segmental fixation. So there were three treatments, and it correlated with the three main forces on the middle column. Now it seems like, I think the other thing I want to bring up is if you have ankylosing spondylitis with a long lever arm and osteoporosis, that's an exception to Alex Vaccaro's classification.
Yes.
That's an exception, and they don't deal with that, and that disqualifies the application. And it's with good reason. We had a really good case yesterday. Technically, it was a complete failure at L4 of more than a 50% compression of the anterior and middle column. Technically, the posterior column was intact, but it collapsed so much with time and it was neglected that it behaved like a three-column injury because it went into so much kyphosis that the patient developed a neurologic deficit.
They were osteoporotic.
So I'm about individualization. You got a great approach, and that's all that's important. And the last thing I'll leave you is, White and Punjabi came up with a checklist even before my classification. Jens, I don't know if you must remember this, because White and Punjabi had a checklist, and it was based on 6. And if it was more than 6, then that meant you should think about surgery. It was for cervical spine and lumbar. And if you had a neurologic deficit, that was 3 points out of the 6. So it shows how heavily weighted their classification was for instability if there was a neurologic deficit. So I think we're all saying the same thing. It's different approaches based on whether you're an anatomist or whether you favor the neurologic deficit more. But I think overall the treatment has really improved so much in the last 40 years. It's just incredible. But the other thing is the injuries are so much worse than what they talked about originally. But kudos off to you. Fantastic talk.
I think of the middle column kind of as a biomechanical concept. Would that be a good way to describe it?
Absolutely. That's what it's all about. White and
Yeah.
Punjabi, my heroes.
Yeah. 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 I guess yeah, sure. Yeah. Augustus. Yeah. Augustus, right. Anyway, um, good comments. I
Editorial
was going to say,
comment, White and Punjabi checklist. I loved the category, which is so important. That's the judgment part on the part of the treating physician slash surgeon. That is anticipated dangerous loading. I always loved
right.
that part.
That's
There were
right.
2 points for anticipated dangerous loading, which never happens in San Francisco, where basically non-compliance slash
it's
injudicious
not just San Francisco.
host were given heavy discretionary valuation by the surgeon. So I always loved that part.
Jens, one of the things you got to realize is that we have to fixate and stabilize these people for the long run because most of them we never see again. They're so lost to follow up. We have no idea how they really do. I've tried to write papers for years and we've got 50, 60% lost to follow up. So we really don't know how they do. So you really got to do them for the long run. So anyway, I hope everybody enjoyed that talk. I was supposed to talk about the historical development of everything and how to treat. So that's kind of where I focused it.
No, thank you. Thank you so much, Dr. Dimar. So I think